Assalamualaikum and hi, I'm Nabilah. Let's talk about interscalene block. So first of all, patient should be in a supine position with head slightly elevated and turned away from the operator. So the most important landmarks here are the clavicle and the sternocleidomastoid muscle. Patient's neck and upper chest need to be exposed, cleaned and draped prior block. High-frequency linear probe is then placed transversely at the supraclavicular fossa. Brachial plexus is identified, and then the probe is moved cranially until the grape-like brachial plexus change to a traffic-like appearance. Most of the time, the final probe position is at the middle of the neck, slightly posterior to the sternocleidomastoid muscle. Then, from the posterior end of the probe, the needle is inserted, aiming towards C5 and C6 roots. Well, it is not advisable to insert the needle in an antero-posterior manner, as the phrenic nerve lies in between the sternocleidomastoid and the anterior scalenus muscle. Now, let me highlight the important structure that we need to identify when performing an interscalene block. Well, this is an ideal sonoanatomy. It shows that the brachial plexus, more specifically the C5 to C7 roots, are being sandwiched between the anterior scalenus muscle and the middle scalenus muscle. So moving medially, the vertebral artery can be seen lying deep to the anterior scalenus muscle. Another important structure that we need to take note is the dorsal scapular nerve, which lies in the middle scalenus muscle. So the linear arrangement of the C5 to C7 roots reminds us of a traffic light, or even a butterfly, with the wings represented by the scalenus muscles and the brachial plexus is depicted by the body. So now let's move on to the exciting part, which is the needling part. This is a superficial block, so the needle length shouldn't be more than 80 mm. So the needle block is slowly being advanced towards the brachial plexus, piercing through the middle scalenus muscle and then the nerve sheath. So the needle tip is placed between the C5 and C6 roots. LA is injected in a small volume, maybe roughly around 1 to 2 mL after negative aspiration. And we can see that the LA is enveloping the C6 roots. The needle is readjusted, so the LA distributed to C5 as well. So during the needling part, it is very important to ask the patient if he or she experiences any pain during the LA injection. Patient might feel pain if the LA is being injected intraneurally. Post-procedure, the things that we need to observe are the common complications that can occur in an interscalene block, like hemodynamic instability if, let's say, we inject LA inside the intrathecal or epidural, dyspnea if we block the phrenic nerve, even Horner syndrome if we accidentally block the stenate gradule. A recurrent pharyngeal nerve blockade can happen, which gives rise to a hoarseness of voice, and lastly is the last, which is the local anesthesia systemic toxicity. So that's gist about the interscalene block. That's all for now. Till we meet again. Thank you.